Hello and welcome. I am Dr. Ryan Kazemi, and glad to have you at our complex case discussion series. We're coming to you live from Bethesda, Maryland, from Facial Art Dental Forum studio. And I'm delighted to have all of you with us. Today we have a very interesting case that we're going to be discussing. My guest is a good friend and a colleague, Dr. Mariano Polack, who is a prosthodontist in Gainesville, Virginia. Hello there.
How you
Nice
doing?
to see you.
Good to see you too.
All right, wonderful. Thank you for being here.
Of course.
Mariano is a graduate of the prosthodontic program from University of Minnesota. He's been practicing in Virginia since 2000. We had the pleasure of meeting each other, I guess, a couple of years ago, and I've really come quite fond of your knowledge, your skills. You're an educator, you're a practitioner, as I am, and really exciting to have you here. So thank you.
Thank you for having me.
All right, very good. So the case that we're going to discuss today is a patient that we both have seen and have treated. So we are going to share this particular patient and describe the complexity of this case. So let me go ahead and get into this patient's case. I'm going to present the history of this patient. This is a patient that came to us in 2020 with the complaints of chronic pain around implants number 19 and 20. The history is that these implants were placed initially in 2006. According to her report, there was a gradual bone loss over the next 10 years since these implants were placed. There were 2 attempted bone grafting procedures to try to restore the bone loss around the implants, but it was not successful. Ultimately, because of the pain and the bone loss that she was experiencing, the implants were removed in 2016. And according to a report, there was some bone grafting done to restore the ridge. About 6 months later, she had the implants replaced. And again, she reported pain around the implants really kind of over the next 3 years after the placement of the second time. So when she initially presented to me in 2019, her chief complaint was continued pain around the implants, which had not resolved in spite of the previous treatments. Her previous team had suggested a bone graft to try to correct the defect. As you can see in the center x-ray, she did go back to her team that initially did the treatment. They raised a flap and attempted a bone graft to try to restore the vertical deficiency. She came back to us in July of 2020, again with continued pain and discomfort, and she advised me that the bone graft that had been attempted did not work and it had failed. And this is the presentation in 2020. So that is the history. On clinical examination, the restorations were removed and a couple of healing abutments were placed on the implants by her previous team. And when she first presented, there was a very distinct pain on palpation on the lingual aspect of the implants. There was quite a bit of inflammation on the lingual aspect. No purulence, however, bleeding on probing. And of course, from what you can see, there was complete lack of any keratinized gingiva. So the cone beam CT scan showed existing root canal treatment on tooth number 21, number 19 and 20 implants, fairly well centered in the alveolar bone, but obviously we can see the advanced bone loss. And this is more evident from this perspective. Number 19 with more normal bone on the distal aspect, but gradually diminishing apically, hence the vertical deficiency. So here we are, Mariano. This is the presentation of a patient, chronic pain, obviously multiple surgeries and procedures since 2006. And certainly there is clear evidence that her pain and discomfort may be due to this inflammatory process. There is no question there is peri-implantitis. But what are your thoughts? What are your thoughts from this initial presentation?
You know, when it's interesting how sometimes implant dentistry can be straightforward, and sometimes you have a situation like this that may not be per se aesthetically demanding, but the patient is having discomfort, and it's like a conundrum. So what do we do? Do we try to heroically try to vertically augment that bone and get, you know, a better result and maintain what she has, or are we better off going back to the drawing board and removing the implants, preparing the site in a better way, and then start all over, starting from the foundation up? This to me is perhaps the most challenging aspect in implant dentistry, because, you know, when you have to, this is more challenging, in fact, to me than something in the aesthetic zone, because it's really there's no easy answer to this type of cases for me. And again, it requires a lot of conversation and discussion with the patient, and patient management, I think, is, as you and I have discussed in the past, is critical here. And the whole team coming together, right? Restorative and surgical. What are we going to do?
Right. I think what's interesting from her history, and I've heard this from patients who've had chronic peri-implantitis or some experiences where they report immediate pain after the implant placement, which never resolved. Like, you know, way after the post-surgical healing, they continue to have discomfort and pain. And I wonder in those situations if there's already a inflammatory process or early peri-implantitis already happening, hence resulting in this prolonged pain after an implant procedure, which we all know should not last. Usually placement of an implant, there's some tenderness, soreness for a few days, and that's what we expect.
Yeah, certainly a consideration. And the other, as you brought up, you know, looking at those photographs you had there, obviously, yeah, the lack of keratinized tissue on the lingual side, I think, you know, that's also a big deal there, making a challenging situation more challenging.
So now the question is, I think, you know, we have to think about what were the possible causes. Was it the implant position? If we kind of look at the span of the edentulous space between number 18 and 21, there seems to be a larger space than just a molar and a premolar. The implants were placed, of course, where they at, but was that part of the problem? Is it possible that there was some potential access for hygiene challenges or issues? Was that part of the causality? Certainly cement-induced peri-implantitis, or perhaps just patient healing in general. I think, you know, we cannot really, of course, tell for sure what the cause of the peri-implantitis was, but I think these are some of the thoughts in terms of what may have contributed.
Probably add, as you mentioned earlier, to the list, the lack of protection from no keratinized gingiva there as well, no, as a compounding factor.
Yeah, absolutely. I think more often than not, especially with thin ridge situations, especially if there is multiple procedures and grafting procedures, we continue to lose the width of the keratinized gingiva. And of course, implants can be placed, and if we don't develop the soft tissue or the keratinized gingiva, irritation, localized irritation, and plaque retention is always becomes an issue. And I think we all have experienced that.
Right.
So I think the problem list that we have is, of course, chronic advanced peri-implantitis. There is vertical bone loss in number 20, and to some degree on the mesial aspect of number 19. There's clearly lack of attached gingiva on the lingual aspect with marked gingival inflammation. It's definitely a very thin tissue biotype, and that could be a red flag in any case, but specifically in her case. But the other two things that I also maybe don't talk about as much is a multiply operated site that has a different physiology, different biology than a fresh area when we do implant therapy. And I want to kind of ask your experience and opinion about that. And also, last but not least, the patient's emotional state. I can tell you that when she came for a consultation, she was in tears, years of pain, years of not having a solution to the problem that she was having. I think there was a very clear sense of frustration, anxiety, and sort of very debilitating for an individual to experience that with no resolution. And I think those last two is something that we don't really talk about very often, but I think they're important factors just as much as everything else that we mentioned.
Well, but particularly here, I think you hit the nail on the head there, because if we look at the X-ray, but the patient was not in pain. Let's say the patient had her restorations there and she was not uncomfortable. We see that bone loss, but the patient is comfortable and functioning, and we don't see progressive bone loss. Would that be a reason for concern or retreatment? And we could argue that let's keep things going while things are functional and she can maintain. But the issue is the discomfort, obviously, and her emotional state that makes this case what it is, right? So how do you support the patient? How do you manage a patient that comes to us with this her own little personal horror story as to I came in, I was told I would get 2 implants, get my teeth and be done, and here she is, 10, 13 years later. Still, back to the start, and to the other point you made, I every time you go back, I think I don't do surgery, but every time you go back, in my experience, to a site that already had surgery done, the vascularity is unlikely to be the same. More scarring is likely, as we all know, and that just again complicates things further. Unfortunately, it makes it more challenging.
Exactly. Yeah. So I think if kind of look at the treatment options, what are the things that we could do? Certainly, as a temporary means, one may do local therapy to manage the inflammation, to debride and perhaps remove some of the biofilm superficially, perhaps to provide some comfort, but it's not really a long-term solution. The idea of doing bone and soft tissue grafting, I think it's something that is always asked, is always talked about. But my experience is that once you get this level of vertical deficiency and this level of peri-implantitis, bone and soft tissue grafting does not work. And I think that was certainly demonstrated by the 2 previous surgeries that she had done in an attempt to restore the bone. So that's certainly not a very predictable outcome there. And the other option being, of course, removal of the implant, and then do what? conventional bridge? Are we going to place new implants? Are we going to try to actually do the bone grafting to try to restore the deficiency? These are all the options that one may think about. What are your experience and thoughts on that?
You know, once the surgical is handled, we have to decide how many implants we're going to be placing. Are we concerned at all about the crown to implant ratio? The literature, you know, doesn't seem to show that there's much influence in terms of bone maintenance, but it could have an effect on the components that I'm going to be using there. Do we place 2 implants again? Do we place 3 implants? And can she manage that? And can she clean appropriately? Or is it, you know, is it better to have less with more space for her hygiene to be adequate? How do we handle the occlusion? Is this, you know, is this perhaps is occlusal in nature, or you know, is there such a thing as the occlusion having an effect on bone loss around implants? The literature is at a minimum debatable on that. Lots of things to consider.
So just to kind of share a very similar patient that this is a patient from about 5 years ago. And when I saw her case, it reminded me of this particular patient who had a very similar presentation, 2 implants, vertical bone loss, almost a mirror image. This is particularly on the lower left side. I just want to kind of, you know, share with you what we did here. And this is certainly an example of many cases that we've managed. And so this patient, the implants were removed, allowed to heal, and then we came back and looked at the deficiency there to look at the possibility of bone grafting and replacement with new implants. Because of the vertical deficiency, a bone grafting technique was done here. This is using the ramus bone and the GBR technique, the classic Curie technique, to restore the vertical deficiency, allowed to heal for about 6 months, following the digital workflow, placement of 2 new implants, and ultimately restored and very successful in this case. Actually, this patient we saw just last month after 5 years, and everything is absolutely stable and very healthy. So we look at these cases, and you know, we can certainly you know, bank on the science and the evidence base to support that this therapy can be very effective. Not easy to do, but predictable if we follow the biological and the functional requirements of this type of case. So with that in mind, we offered her the following treatment sequence. I think the first thing that we talked to her was about getting her out of pain. There was really no good way to manage the advanced peri-implantitis except to remove the implants. So we talked about the reverse torque removal of the implants, give it a couple months to let the soft tissue heal. No grafting at that point, simply because we just want to get some soft tissue health and some vascularization into the area. And then we can come back and look at the option of doing a bone graft to augment the vertical deficiency, similar to the case that I just showed you. And then come back 6 months later and place 2 additional implants, or number 19 and 20, replace them. Of course, look at the soft tissue, revise it, graft it to increase the zone of keratinized gingiva, which she clearly needed, and then getting her into the restorative phase. So this was a treatment sequence that we had followed in the previous case, and also was offered to her. Any thoughts on the treatment? Does this sound like a good plan?
I think you're doing great. No,
okay.
To me, obviously, it's yeah, no, it's we have to start figure out, you know, if the pain is coming from present peri-implantitis, and then build up from the ground up here. I agree.
Okay, very good. So really the first step was the explantation to remove the implants. For this, the healing abutment is removed. Here we can see the two implants, which were incidentally standard size 4mm implants. We can appreciate the lingual tissue being, again, very erythematous and lack of the keratinized gingiva. The floor of the mouth, the floor of the mouth pretty much right there, and the mucosa kind of running here. A little bit more tissue on the buccal aspect. So for the removal of the implants, and we've talked about this in our some of the previous presentations, using a reverse torque technique to remove the implants. This used to be a very, very difficult procedure using the troughing techniques before, but now with the reverse torque technique, we can effectively remove implants that are obviously in place since 2016, well healed, well integrated. And it's interesting that with about a 250 Newton centimeter of reverse torque, the bond can be broken quite easily. So here's the first implant that is removed. And right away, we can kind of appreciate the level of the plaque and calculus and biofilm buildup. And this was very hard. This was not easily removable, very much tightly attached to the coronal aspect of the implant. Second implant also removed effectively using the reverse torque. And because of the probing in the mesial aspect and the vertical bone loss, we had suspected that there is certainly some plaque and calculus and biofilm on the surface of that implant as well. And of course, as soon as the implant is removed, we can see very much clearly, right in the mesial aspect, the presence of the calculus and plaque and the biofilm. The rest of the implant was quite well integrated. Here is a segment of the bone that was in the caudal aspect of the implant. And we can see the really a tough attachment of this residue. So there was certainly no cement in this case. My guess is that because of the thin tissue biotype, that there was some early bone loss. And because of the fact that these implants were more apically, access for hygiene is not easy for anyone. And I suspect that that probably was a contributing factor to the plaque and calculus and development of what we just saw. Anyway, afterward, we gave her a transitional prosthesis, just an Essex appliance to hold and give her a sense of something in the gap. We have talked a lot about transitional prostheses in any of these surgical cases, and we've advocated and really encourage use of a non-tissue bearing transitional prosthesis. An Essex appliance is simple, easy, and very tissue friendly. Certainly not very functional from a patient standpoint, but certainly it does protect the tissue better. So we waited about 2 months for things to heal. She was now comfortable, out of pain, and I think for the first time she had a sense of relief. But nevertheless, not very happy about not having teeth. So one challenge resolved, another challenge ahead. What we can appreciate is that there is an extensive amount of scarring tissue, very thin width or band of keratinized gingiva, and a cone beam CT scan showing pretty much the level of the bone that we had. This was not grafted. It was simply just allowed to heal naturally as a regular socket healing. And that's what we ended up in about 2 months. So based on the sequence that we talked about earlier, we talked to her about the advantages of graft in the area. We spoke about placement of the implant into the existing bone. And one of the things that we addressed with her was that if we were able to place the implant exactly where the bone height is, we might be kind of back into the same situation, mainly because of the difficult access for hygiene and implications of that. So she agreed to attempting to correct the vertical deficiency and hopefully allow us to place that implant in a better position from an apicocoronal position or depth. So for that, really kind of, I followed the same technique that I presented in the other case. This is the Ramus bone using the Curie technique by placing that and holding it with a couple of fixtures, using autogenous bone and allogenic bone along with platelet-rich fibrin to pack the lateral aspects, coronal, as well as the space between the bone graft and the mandible itself. This was then covered with a resorbable membrane here and sutured in place and closed primarily. Really went well. The closure of the incision was tensionless, adequate amount of mobilization to make sure that the incision doesn't break under tension. And as you know, that despite of the best techniques, materials, intentions, complications happen. I think you've experienced that. I have experienced it.
We all have.
It makes us humble. We all have. Because what happened after the bone grafting was about 10 days later, she developed a severe infection. She developed purulence, increasing in pain, which she was placed on antibiotics right away. It helped to some degree. We did an incision and drainage in the vestibule to try to drain the purulence and put her on antibiotics for 2 weeks. The infection ultimately resolved. It took about 3 to 4 weeks to gradually let the tissue settle down. But about 3 weeks later, when I took a cone beam CT scan, I could already see something that I didn't want to see. And that is the gradual loss of the bone graft in the interpositional area between the cortical bone superiorly and the mandible itself. We would expect to see some increased radial opacity from the bone graft material, but it was clearly not there. Granted that it's immature, but the radiolucency that you see here tells me that the bone graft is gradually being lost. You agree with that?
Yeah, no, yes, it's like you said, something we don't want to see.
Yeah, absolutely. Now, look, I'm going to tell you something that I think a lot of us have maybe in some points during the treatments we hope for things to happen and go in the right direction. I call it wishful thinking. Even though we know the biology and we know the outcome of such an infection is not good in this graft, I try to be patient. I try to make the rationalization that maybe if the infection resolves, that we can actually try to salvage part of the bone grafting, maybe not the entire thing, but at least part of it. And if we have at least some of it survive, it'll be better than nothing. So with the infection resolving in here, decided to just monitor it. In some cases, it may be better to go in and remove the entire bone graft, knowing that it's compromised, knowing that the outcome is not going to be great. But considering what she's been through, I wanted to have some hope or at least some attempt at seeing what we can salvage here. So we tried to hang in there. Infection actually did resolve, but 4 months later, we still had an area of tissue dehiscence. The superior aspect of the bone graft was exposed. It never quite closed over that 4 months. And there was some tenderness in the region. So pretty much at this point, we know that if the bone graft is not survived, it's not going to work. At this point, I did an exploration, incision, just to see if the bone graft is stable or not. And clearly it wasn't. The bone segment that we had placed in the superior aspect was mobile with some fibrous granulation tissue in between, and it pretty much was easily removed. Irrigated the area, closed it with a resorbable suture, and she was sent home. So I think, the lessons learned is that we have to respect the effect of a deep infection around the bone graft is generally not good. What is your thoughts?
Yeah.
The reality of life, we have to accept it.
Back to your slide, despite best intentions, and you always want to do, provide a service for the patient that is satisfying, that solves the problem. I think we all start from that premise of being problem solvers, and sometimes we're gonna need to be more creative and think again what we're gonna need to do, like here, like you're gonna show now.
So another question is, what's next? So we have a patient who, again, went through another complication with pain and infection. Of course, immediately after the removal of the bone graft and irrigation, the site healed quite well, and she was comfortable again within a couple of weeks. But the question is, what's next? Her emotional state was not better. If anything, there was even a deeper sense of disappointment at what could have been. And now we have to think even more about the site's healing physiology. We added one more operation to a multiply operated site. So what's next? What are you thinking? What can we do? Should we proceed with another grafting procedure? Should we place the implants where the innate bone is at this point? Should we consider a non-surgical approach? What are the risks and benefits? So this patient is in your office, Mariano. What are you going to tell her?
So from our
and you can thank me later for this.
Yes. No, of course. It becomes more and more complex from a restorative standpoint. Are we going to try implants again? Then we can plan for that. The non-surgical approach, we have 2 teeth that are endodontically treated. I think when you and I were discussing before the case, there's a questionable lesion on the bicuspid potential there. So are we going to be fabricating a long span, a fixed partial denture? And what's the long-term prognosis for that? Are we condemning the abutment teeth in that case? And then are we bringing the patient back, a few years down the road with an even bigger problem with a whole quadrant now that needs to be addressed? These are difficult questions. The best that we can do, as in most cases, in my opinion, is to lay it out in front of the patient and let them know. We can put implants. The risks. What might happen. we could try a non-surgical approach. But the challenges are what I outlined for those potential abutment teeth. It's a difficult choice for the patient to make.
Yeah, so I actually spoke to her about attempting another grafting procedure if she would allow us to do it. But at the same time, we acknowledged two things at this point. And this was actually a very frank conversation with the patient who has been through a difficult journey. We had alluded to the emotional state of patients that we treat, any patient, and I have spoken to a number of colleagues, and I know I've spoken to you about it, about when we have a patient who may have a lot of anxiety, stressed, their emotional state is very negative. They're not quite maybe physically healthy, but emotionally and psychologically, there are challenges that are going on. And I wonder that how often we don't think about that, because I think if I look back at a number of complications that I have experienced over the last 30 years, I can tell you exactly the patient that I experienced it on, and almost every time it was someone who had been in not a very positive energy, emotional state, whether it be depression, whether it be anxiety, whether it be stress. I think something there is not helping the physiology of healing. And I wonder that if we need to really pay more attention to that. I think it's a red flag. I think we need to slow down a little bit, maybe have more conversations about not so much the dental or even medical or even their health, but their state of life, what's going on in their life, whether or not there is other things that's stressing them. What is your experience when it comes to these conversations?
Yeah, for sure, there's a lot of evidence that the emotional state will affect the overall, from the immune response to everything else. My question would be on these patients that come to our practices. Is it which one comes first? Is it a chicken or the egg type of situation? Are they starting with a particular state of depression or whatever it might be, challenges of that nature, or are they reaching that state because of an experience, going through treatment that wasn't successful? Certainly, before we start, if we can pinpoint to and have knowledge of those challenges, then before we start is a different situation. But when you meet this patient, I think that, the influence was already there because of her experience. She was influenced by the experience she had. So at that point, it's like, we need to provide some kind of solution, or at least present her the tools to make a decision. But certainly an aspect that we don't explore enough. I agree with you.
Yeah, I mean, it's certainly from a risk management and trying to meet a patient's expectations, I think it's not just another layer of conversation that I have become more and more sensitive, more attentive to. I think we need to have those conversations. And perhaps for someone who's not ready, perhaps emotionally, that we could wait, we could speak to them about how maybe to overcome that before we try major procedures. Sure. So it's something that I want to, kind of pay more attention to, certainly in hair particularly. So, so in an attempt to try to see what our options are, we just did a trio scan, optical scan, and tried to do some treatment planning. The treatment that you and I discussed was, if we decide to avoid additional bone grafting, can we provide her with existing, 2 or 3 implants in the existing bone and provide her with maybe a soft tissue graft, perhaps to just give us more keratinized gingiva, but to go a little bit of a less surgical approach. So we did a 3D design. You and I actually got online. We looked at this. We looked at a couple of different crown designs. Initially, we had a more of a molar-sized crown and one implant and a premolar. And when we looked at it, we just agreed that there was too much of a span in between. And because of the fact that the mandible is already thin, we couldn't really put a wide diameter implant. So we kind of revised it and decided to look at the option of 3 restorations into a more premolar size restorations with 3 implants instead of 2. This is how the emergence of the implants would look and the occlusion. And here's a cone beam CT scan. We have adequate width and height for placement of these 3 implants. These are standard size 4mm diameter by 8mm length implants. What do you think about this option? Because you and I talked about it. What are the implications in this type of design?
First and foremost, can she keep that clean? Can she maintain? Is she going to be able, as you mentioned earlier, hygiene and access is challenging for, in my experience, for many patients, and that's one of the factors. The other concern long term is the slope of the bone, both distal of the bicuspid and mesial of 18, as we discussed prior to that, makes it challenging, for the patient to keep that that clean. So looking at it, I mean, this could certainly work. It would be interesting to see when she's ready to move forward, to make a decision and how the soft tissue looks, to see if she would benefit from 3 implants, perhaps splinted like that, or maybe do 2 implants and leave a pontic in between where she has a little bit more room to clean underneath. I think that that may be something to consider at the time.
So you would certainly consider the splinting of the restorations. I think that's pretty clear.
Yeah. If I mean, assuming this approach, yes, with short implants, I would prefer to splint. Certainly, the literature supports that as well. Monitor the occlusion and occlusal guard. I pay close attention to all the details in this particular case. The crown to implant ratio, as far as bone, to me, I'm not concerned about that personally, but in terms of the mechanics,
right.
Splinting for sure. So she has to be able.
Yeah,
to
I think. Yeah. So really, I think it's interesting because we now the evidence tells us that the crown to implant ratio is something that is not as adverse as what we used to think. Having said that, any type of lateral off-axis forces can have some impact. Now, if you're splinted in here, probably would not be as concerned about it, of course. But if this was a single unit implant, how would you control that? Would you be more concerned if this was a single unit implant in a case like this?
Yeah, it's interesting because there's so many things that we do, because we I guess empirically transfer from the natural addition onto implants, like crown to root ratio, crown to implant ratio, and in terms of avoiding, if we had a single unit, traditionally we were taught, okay, flat cusps and narrow occlusal table. And again, when you look at the evidence to really have an impact, you have to almost completely destroy any sense of anatomy to really have an impact on those lateral forces, not having an effect and increasing stress under loading. So can you really do it? Can you really flatten those cuffs enough that it would have meaning, or are you just doing that because it makes you feel good? You know, is it emotional support for the prosthodontist? Sometimes maybe I think that's the case.
Yeah.
Splinting would have a lot better, I think, would result in a much better effect to prevent rotational forces, obviously, once you have multiple units, than having single units like this, just for sake of discussion, not that you were going to approach it that way. Single units with flat cusps. You know, I much rather splint. I think that would certainly achieve more in terms of force distribution and avoiding rotational forces than single units with flat cusps.
Right. So the other question is the challenge when we look at the space between the implant and the teeth, because we have a fairly normal interseptal bone level on the premolar and the molar, and it drops off down, and the level of the implant has to be more apical. So one of the challenges is really the sloping of the bone on the mesial aspect of implant number 20 in this case, and the distal aspect of number 19 in this case. You know, the emergence phenomena and creating a restoration abutment that keeps the area as accessible as possible when it comes to hygiene, not an easy task.
No, very, very challenging. And when you have bone loss like this, even more so, I think when the time comes, definitely a consideration would be looking at the contours of the adjacent teeth, you know, because certainly I think another issue with interproximal contacts, I much prefer to have long contacts that look almost like guide planes, as you would prepare for a partial denture, for instance, and that may certainly require restoring 18 and 20 again, and to make those modifications, leveling the bone interproximally, perhaps to facilitate that process and her access, I think that's what you were referring to. That's another consideration.
Yeah, very good. So in the last few minutes that we have available, I don't know if we have questions, so I'm going to go to our Q&A.
So Keith Programming is asking, is there peri-implantitis currently? I guess when you were showing the case, bone loss around implants or inadequate ridge, what is causing pain? Allergic reaction to implants? I guess the question was if there was peri-implantitis at the time. I think that was at the time when you saw the patient. Inadequate ridge. I mean, the CBCT did not show that. You showed adequate bone, right, around those implants. It didn't look like it was a question of inadequate ridge.
No, the width was fine, yeah, but I think, you know, we confirmed the fact that peri-implantitis was confirmed with the older implants. Yes.
What's your experience with
allergic reaction?
Yeah, what's your experience with that, with allergic reaction to implants?
So allergy, but that opens a whole different side of the conversation.
You take that one.
You know, there are some who have reported. I'm not sure how much of it has been reported in the evidence based in the literature, but sensitivity to not so much titanium, but to other alloys in the implant itself, particularly if there is nickel, that certainly is more common when it comes to metal sensitivity and allergy. The question is, how does that manifest itself? We don't know. You know,
I'm gonna sort of segue into prosthetics now that we're talking about metals and alloys, and it's been reported separately, and this will tie into the splinting or not splinting. You always have some degree of micromotion between your restoration and the implant. And although it's been more reported for abutments that we used to have with zirconia connections into the titanium, it's also been reported for titanium on titanium. When you have this micromotion, something happens called fretting corrosion, and that titanium can leak into the tissue. Splinting may be able to prevent some of that micromovement when you're connecting. So that's another consideration, or reason why splinting may be warranted in cases like this.
Yeah, I agree. Next question in the Q&A, did she elect against more surgery? So she was not opposed to it. However, during the last meeting, she was having some additional stress in her life with family members going through some health issues, as well as finally she was at the point of being comfortable and being out of pain. So it is on hold at this point. The plan is no additional bone grafting, mainly because she said that she just doesn't want to go through the surgery again. So we're, I think, inclined toward the 3 implants in the existing bone, but we'll see. You want to read the next question on chat?
Yeah, sure. So opposing dentition an issue, bruxism not being managed. Seems that the occlusal scheme of the existing restoration on these implants, not a level occlusal plane. So, okay, this is another one that we could spend a few days discussing. Is occlusal overload an issue for bone loss? Personally, I don't think the literature supports that. I don't think, certainly it could be an issue for components, absolutely. Prosthetic materials, yes. But I don't think you can show, in general, I think today, if you look at the literature, what you'll see is that osseointegration is perhaps the strongest component out of the whole complex, crown, abutment, implant, etc. And you will basically, you wouldn't be able to break that down without first fracturing the implant or having some other consequence in another part of the system. So I'm not a believer that you'll get an implant failure because of overload. In general, I would say I'm a little bit skeptical about that.
Yeah, I agree with you. I think we have a number of papers that have come out that allude to that. What seems to be the consensus is that if there is overload, we might see manifestation of it in perhaps fracture of the restoration, loosening of the screw or the abutment, but not so much bone loss. I don't think peri-implantitis bone loss is a direct effect of it. Now, it may be a cofactor, but it's,
Right.
I don't think that's been clearly shown.
Yeah.
We have time for well, we have another 5 minutes. What else we got? You want to sink into the next
Yeah,
one?
this is a good one, Keith. Is the infection from the tooth behind with the RCT, does that tooth need retreatment of the root canal treatment? So this is great, and again, reported. I mean, you may not remember this, Keith, you may not remember this, but we were maybe now 21 years ago sitting at a study club in DC, and we started discussing a report that came on the Journal of the American Dental Association about endodontically treated teeth with diagnosed or undiagnosed lesions having an effect on implant integration, surgical failure, etc. So great point, and certainly, worth exploring for a patient like this.
So this particular case on tooth number 21, there was a widened PDL, a very, very small lesion, but not large enough to affect the implant. Having said that, a pre-surgical endodontic therapy, a pre-surgical endodontic evaluation is always a recommended strategy. I agree with that. Important. In this case, the lesion was, I don't know if I can even call it a lesion, maybe a scar tissue to some degree. The tooth was percussion negative, no probing depth, and seem to be stable.
Right. There's one more. Crown lengthening on 18 will help tissue heights, open margin on crown 18, and may retreat endo. Sort of circling back, and yeah, and what we mentioned earlier about making it you know, restoring and making it easier, facilitating access for hygiene, I think, and allowing for better interproximal contacts, greater surface area on those contacts, certainly. Yeah.
Mariano, I think we're still treating this patient. This is certainly was
We
a conversation
continue.
about the next steps.
Yeah.
But we know that I think the next step is going to be the conversation about the two treatment approaches.
Mhm.
We'll share the outcome of this down the line and hopefully present it in a future program.
Perfect.
But I appreciate your insights and being part of this conversation.
Always a pleasure. Yeah.
Thank you, everybody. I think we're right on time. Thank you for the questions. Just to remind everyone that we will have this program on the website, facialartdentalforum.com, which can be accessed for future viewing. Thank you very much, Mariano.
Thank you.
You're awesome. Thank you for being a guest here. And we look forward to seeing all of you very soon.
Great.
Thank you.
Thanks for having me. Have a great evening. Bye, everybody.